Hello, I'm Dr. Marilyn Goski, and I'm a pediatric radiologist at Cincinnati Children's Hospital, and I'm also chair of the Image Gently campaign. And I'd like to thank the organizers for inviting me to participate in this very ambitious virtual summit. And in the next 20 minutes, instead of talking about standards to adopt protocols, I've actually changed the name of this talk on this next slide to Challenges to Developing Protocols in Your Facility. Next slide. So the goal of this talk is to share general confusion and my confusion and frustration that exists in the radiology community about the development of CT protocols for children. My next slide gives a disclosure. Click. I am not a medical physicist. My interest is in patient care as well as medical education, and I'm hoping that if you have some difficult questions that you save those for some of the exceptional medical physicists that are involved in this symposium. Next slide. So the purpose of my talk is to demonstrate protocol variation among institutions. I'm going to discuss the complexity of protocol development. I'm going to describe a new approach for protocol development. I'll discuss quality in the context of a radiology practice and describe some available tools for improving quality in your institution. Next slide. So first we'll talk about demonstrating protocol variation. Next slide. So I think that developing standards for protocols is kind of like the wild, wild west. And if you review the literature in this area about developing protocols, it's actually very sparse. And so what I'd like to do then is talk about some of the challenges that I found in trying to figure out how to develop protocols. Next slide. I have the good fortune of working with Dr. Shirk Westra from Mass General Hospital on the AAPM Working Group on Standardized CT Nomenclature and Protocols that is chaired by Dr. Cynthia McCullough and Drs. Diana Cody. And this is a pretty amazing group and ambitious task taken up by a large group of medical physicists from the academic community, medical physicists from manufacturers, representatives from the FDA, radiologists, and other professional societies. And they've really spent over 2 years trying to develop standardized nomenclature across the different manufacturers, as well as to develop CT protocols for adults. And you can go to the AAPM website and use this as a valuable resource for your facility. And currently, our group is starting to work on developing some protocols for pediatrics. If you go to this next slide, when Dr. Westra and I joined the committee about 4 months ago, we were asked to get some representative samples of pediatric head CT protocols from academic centers to share with the rest of the group. Click. And what I learned from this exercise, click, is that there is very little consensus as to what elements of a protocol should be, let alone a specific consensus on specific technique. You can see from this slide that some were very complex, some were very detailed, and it's actually taking another medical physicist to try to put these very disparate protocols together to come up with some common denominator. Next slide. So which of those protocols is the best? Next slide. There was a recent article that talked about establishing pediatric CT, and it states it's important to know how to modify individual scanning parameters to understand the consequences of each modification. But on this next slide, you can see what is it that you modify. This is an incredibly complicated process. And as each parameter changes, it has implications for the other parameters. And this has significant implications then for quality and dose. On this next slide, what I'm trying to relate is some very specific comments about protocols. And one of the first things that you'll see is that you really cannot share protocols unless your scanner is identical to a colleague's scanners. And very often we would get requests for protocols from Cincinnati Children's, from somebody with a Philips or a Toshiba scanner, and it really would not work. In addition, these protocols really need to be specific for your institution and your radiologists. They should be specific to the clinical task, such as CT scan of the head for trauma versus CT scan of the head for ruling out abscess. And they should also be based on body size. On this next slide, you can see that there are two images of a small child's abdomen. And what I want to point out to you is that on the left slide, image A, this is obviously a higher technique or dose. There's a lot less noise. And image A in a facility that may be primarily adult focused may require increased radiation dose and less noise to come up with their diagnosis, where at another institution, maybe a dedicated children's hospital, where they're used to looking at small bodies without much body fat, they may be able to accept more noise and a lower technique. Next slide. We talked about in one of the other talks about how different tasks may require different techniques, and we give this example of a renal stone protocol. And on the next slide, the lowest image was at 40 mA. Again, this was simulated, and you can see that this higher contrast object of the tiny renal stone was identified by one of the pediatric radiologists. By the time they got to 80 mA, all of the pediatric radiologists could identify the stone. And finally, at the original technique of 240 mA, that everyone could identify the renal stone. Next slide. So now we're going to talk about the complexity involved with protocol development. Next slide. And I really like this picture because I think it demonstrates the frustrations that many of us have had about developing protocols. Why don't we have standard protocols and practices? And I think one is that it takes a lot of work. You really have to get to know your equipment. You have to have a team approach, including the CT technologist, the radiologist, and the medical physicist. I think it's been difficult in the past that there hasn't been much guidance as to how to develop these complex protocols, so it leaves many of our sites developing or reinventing the wheel. Next slide. And just when you think you're done developing your protocols, a new technology comes along, as this case, such as automatic exposure control, or now the new iterative reconstruction, and you need to redo your protocols again. Let's go to the next slide. So I wanted to tell you about two helpful papers that I found on the literature, but I mainly want to use them as an example of how challenging it can be to develop protocols. So both of these articles talk about how to develop protocols or change your protocols when using only a KV as the variable. So the first article in this next slide is a highly technical paper, but it developed a novel method to ensure and measure image quality, and it was done automatically. And they went through a series of steps and how you should select the most dose-efficient tube potential, taking into account patient size and diagnostic task. And they found that the dose reduction at each tube potential varies significantly when taking these two parameters into account. So the bottom line on this article, on the next slide, is that this is really a complex task. Let's go to the next slide. This other paper from this same group described a method that can be used to work on lowering radiation dose using tube potential. And it talks about if you lower tube potential too much, you have a problem with contrast, noise, and artifact, as well as potential problems with scanning speed. Next slide. So this article talked about a stepwise approach that I found very helpful, that what you would want to do is determine your lowest acceptable noise level using 120 kV. You would then create a weight-based technique chart, or as we advance, maybe a body size technique chart for tube potential and tube current settings, and then finally refine the techniques again at 80 and 100 kV. And again, I think what I'm trying to show you on this next slide is really a summary, that even just looking at one parameter such as this, determining optimal tube potential, is a highly complex task. Click. I encourage you to call your medical physicist, click, and work as a team, again, to develop these protocols. And I guarantee that as you do this, you'll find that you really learn a lot about your equipment. Next slide. Now we're going to talk about a new approach for protocol development. And on this next slide, you can see that in the past, what we would do is we would start by having a protocol. We would then scan the patient, and we'd see what the dose estimate was in CT-DI-vol. We would record it in PACS or maybe in the chart. We'd monitor periodically. Click. The problem was that once the scan was completed, and if the patient had received a higher radiation dose than necessary, it's actually too late for that patient. A newer approach is demonstrated in this slide, where you really start out with looking at the desired quality that you want, the dose in SSDE, that is your target, and you work backwards to develop your techniques that you would need to hit those target ranges. You can then monitor the patient, you can then work to reduce variability, you can then check for outliers and go back to your scan itself and find out why that patient is an outlier in terms of radiation dose, and then finally you compare your doses to national standards through a registry. This is another article on this next slide that talks about a quality improvement approach to developing protocols. And I thought this was also very helpful because it reminds us that these should not be happenstance or haphazard, but there should be a process when looking at protocols and trying to monitor them for safety standards. And again, they used a process improvement approach to estimate effective radiation dose levels. They formulated their goals, how much they wanted to reduce the radiation dose using effective dose. They then modified their acquisition parameters, again, before the patient was scanned, and then looked at its implication on image quality. On this next slide, then, we're going to talk about some quality. What is quality in the context of a radiology practice? Let's go to this next slide. And this is one definition of quality. It's described as the degree of excellence. On this next slide, that was borrowed by Dr. Steve Swenson, a quality improvement expert in radiology at Mayo Clinic. He describes quality as no needless variation, waste, or defect. And I think this gets into the next idea of quality on this next slide, and is an illustration about variability and how little we know about routine radiation dose estimates within the medical community. So this was a very good study, and really one of the only few that I am aware of that talks about variation in pediatric head CT imaging in the state of Washington by Dr. Canal. On this next slide, what she did is she sent out surveys and looked at 5 different trauma center levels. And what she found was that at the level 4 trauma centers, the lower acutely ill centers, that there was wide variation, as you can see on this graph, circled by the blue circle. She also found out that for that level 4 trauma center, that there was 10 times variation in effective dose among the different hospitals, and that the dose range went from 0.6 to 9.6 using effective dose. I want to go on this next slide and give you an example about the type of simple project that you can do for practice quality improvement that will help to improve the standard of quality in your practice. Many of you are aware on this next slide about this acronym called the PDSA cycle, or Plan, Do, Study, Act cycle. The idea is that you want to plan the test, or plan the parameter that you want to study. You want to then study it. You want to look at your outcomes, and then you want to act on the knowledge that you gain. And the purpose of this is to improve quality for patients, reduce error, minimize medical legal risk, and save money. So here's an example. We had at our institution, some of the radiologists noted that the scan length was longer and varied from patient to patient. So Chris Alsip, our Chief CT technologist and quality improvement manager, decided that he would look into this. So he planned for the test by going back and seeing the difference among different technologists as to a good scan length or a longer scan length. He then went ahead and did actually measured for each technologist the variability in the scan lengths. Then he actually sat down and spoke with the different technologists to inform them about the goal and the change. They did some in-services on this to define what best practice was. And then finally, he developed this run chart that shows initially the variability. They developed a target level. They wanted all technologists to hit 95%, having their scout view be within the certain levels from the apices to the diaphragm that they had set up. So on this next slide, you can see that what we're trying to get, just like that idea that you can go to McDonald's anywhere in the country and anywhere in the world, that Big Mac is going to be standardized, that is the type of thing that we want to work towards in pediatric imaging. Some of the other methods that you can use to establish quality are to use the dose index registry, as we talked about before, and this will provide actual comparisons of your facility and how you stack up compared to other similar facilities around the country. And you can actually then work on improving your practice. The Joint Commission has also provided some statements that are shown on this next slide, and I've not included all of them. but 21 different actions that you can take in your practice to improve quality relative to radiation dose. And they talk about reviewing your protocols every 1 to 2 years. And I think that most of us would agree that's probably about the minimum. Another resource regarding quality I wanted to show you was developed by Mr. Keith Strauss, who is our medical physicist for Image Gently. And he developed in 2008 something called Universal Protocols. This is available on the Image Gently website, and it's been downloaded over 24,000 times. And this protocol allows you to take your ACR accredited adult doses that you use and incrementally find a conversion factor to use to lower dose for your patients. And all the instructions are on the website. The AAPM also has a wonderful slide set that you can go on that's free and use for your use. There are going to be increasing number of vendors who are going to be coming out with systems that can manage and help monitor your radiation dose. But I think finally what we really need is a completely automated system for monitoring image quality that you can see on this next slide based on patient size. And we need to be able to predict and control the radiation dose prior to the exam. We want to be able to confirm these results. We want to be able to monitor and record it and do it all through automation. And I think that this really is coming down the pike so that many of the discussions that we've had with protocols in the beginning of this talk may become less relevant. So again, I'd like to thank you for listening and really appreciate this opportunity to participate in this virtual symposium. Thank you.